What's up, world? How's everyone doing? Today, once again, we have Dr. William Bridge on the Psych Life Podcast. How you doing, William?
Hey Juan, I'm doing well, man. Thanks for having me back. I'm excited to talk about today's topic. Should be a good one.
Yeah, William. I wanted to talk today about medication use and psychotherapy. And, the first time I ever met you, I remember we had a conversation about this and how sometimes, and we're going to get into some research here on how sometimes people rely on medication solely for their symptoms of anxiety, their symptoms of depression. And I think we had a conversation that medication is very useful when used properly. It's one of the many variables for health when someone is struggling with these symptoms. And wouldn't you agree that medication can be useful? And maybe you can refresh me from our last conversation.
Yeah, I just, my take on it is, I never knew that in med school that a majority of my career and practice would be spent with time taking patients off of medicines. So much of the time, I feel like medications are causing a lot of the symptoms we're trying to treat in the first place. So, like we touched on yesterday, before we implement any of the options of medication, it's very important that we address those things that should be taking place as part of the daily routine, making sure the sleep hygiene is there, and exercise routine and nutrition, and making sure you have enough time to meditate, self-reflect, and all of these things need to be in order before you even kind of bring to the table the conversation about treatment. Now, treatment could be medications. That's, they're always going to be available, but also part of that is, psychotherapy and so forth. So I always, give a patient an option of, these are my three top options that I think are all, viable treatment steps, and kind of weigh out the pros and cons of each, and go from there.
What's interesting, just for the audience out there, thank you for that, William. You mentioned that before any medication can ever be prescribed by a physician or a psychiatrist, we should always take a look on their lifestyle, the patient's lifestyle, what's going on. So just to give the audience a little bit of, let's say, an example, if someone's struggling with their sleep pattern, that doesn't mean they should automatically go to the store and start buying melatonin. That doesn't mean that, or that doesn't mean all of a sudden they should be prescribed by a physician some sort of medication to help them go to sleep. It means that we need to explore their lifestyle, explore what's going on, what are they doing before they go to sleep that is leading them to not be able to go through the proper REM sleep cycle and the proper patterns of sleeping. So I appreciate that, William. And if people want to learn a little bit more about lifestyle, check out our previous podcast, season 2, episode 1. Now, I have some interesting information here, William, and this is from Psychology Today. And I was also looking at the National Institute of Mental Health. It says here, almost all of the federal dollars spent on mental health research goes to drugs, not psychotherapy in clinical trials. And by it saying almost all, it says 95%. William, that is a big number, right? And I can understand why they put so much research into drugs, because before it's prescribed, they want to make sure it works properly. They want to make sure the proper clinical trials were done. But shouldn't society try to almost engage their health without some sort of exterior substance within their body? And we're going to keep this conversation simple for the audience, because you're a psychiatrist and I'm a psychotherapist. So this is an interesting back and forth.
Yeah, for sure. I think that, and it's unfortunate, how, and it's really all specialties of medicine are very, pharmaceutical driven, so to speak. So, let's just say, Juan, you and I had an idea for a medicine. We had a way to, kind of a different mechanism of action of increasing certain neurotransmitters to help with happiness and motivation. From the idea to getting it to the prescribable level, nowadays they say it's 10 years and about $1 billion. So from idea to, pharmacy, so to speak, that's the type of resources, both time and financial, that you need to be able to drive it to being prescribed. So you can imagine whatever grants or research grants or whatever the case may be that's available. That is, if there is a medication that's, going to market, that's going to be a huge consumable side of that, stipend, so to speak. So I think that it's very, very important that you kind of look at there's got to be cheaper, more efficient, or equally as efficient and efficacious ways to treat some of the anxiety, depression, insomnia, and so forth. And I think that that's where psychotherapy comes in. You've heard me say it probably many times before. There's, in the perfect world, everyone would get to, go talk with a psychiatrist, psychotherapist, whoever the mental health provider is, because we all need to, vent and kind of get unbiased feedback from somebody who's a professional. So, I'll end by saying that, all of the studies that we do have that look back, and you take a look at a patient that was receiving both medicine and psychotherapy, their outcomes, especially in the world of depression and anxiety, are better than if they were just getting medicine alone or just getting psychotherapy alone. So I think there's a role for both in everybody's care. And there's not a patient that I don't recommend giving both sides of treatment to if they're up for it.
Thanks for that, William, for that statistic. And I also want William, I appreciate that a lot, man. And that statistic at the end. But you know what I found interesting from what you said? It takes 10 years. It's a 10-year process from the time that we have an idea about a specific medication or a specific drug, it takes 10 years for it to go through the clinical trials, the testing, and then all of a sudden for it to be, if it passes all the trials, then it can be given to the public or accessible to the public through a physician, legally. And that's a long process. That's the first thought I get, that it's a really long process. But then, as you kept talking, I realized that process is necessary, because if it takes 10 years, it's for the safety of the patient and it's for the safety of the person consuming it. So I understand why, but at the same time, if it's taking 10 years and it costs billions of dollars, then I'm wondering, as a psychotherapist, because I'm not in this world, how much pressure or how much is there? Yeah, actually pressure is probably the word, for it to be prescribed, since so much money was spent on the clinical trials. That is the part where I've always wondered, and I've always had questions about, because if something costs a lot of money and it has to go through a lot of tests, I'm assuming that once it finds out that it works, it can be effective for treatment, then it's going to be pushed to be prescribed. But I remember you telling me one time in a private conversation that that's not the case, right?
Yeah. I think that it really more so used to be the case. I would talk about really in the 80s, early 90s, that was more the case. But if you think of it, and by no means defending one side or the other, but when you have a pharmaceutical company that's a multi-billion-dollar corporation, what comes along with that is endless resources. So, yes, there's pressure to, push your medicine to the pharmaceutical reps, who then go to our clinics or our hospitals and they present their evidence behind it. But, this isn't a company that if they don't sell a certain amount of medicines, it's going to be withdrawn. They have, there's no shortage of financial resource. So in the 80s and 90s, that was the time when, pharmaceutical companies, so to speak, got the really bad reputation of, offering doctors trips to Hawaii if they prescribe this many amount of, whatever the medicine was, let's say Abilify, or, you can World Series tickets if, this many patients are on. So that's why, every overseeing entity got involved once we saw what was going on. And that's no longer the case. I mean, pretty much there's none of that anymore. I mean, they'll have these pharmaceutical dinners where you can go and listen to a presentation, but other than that, there's no pressure. I mean, if you don't want the pharmaceutical reps coming into the office, then they don't come, so there's just, there's a lot, nowadays, a lot more very necessary boundaries than there were, 30, 40 years ago. And I think that's a good thing for patients and the specialty alike.
Man, I'm so glad you're on this podcast, man, because that was really cool information there. And I knew that there was some sort of backstory to it. I didn't know what it was, but I'm glad that you're mentioning that the pharmaceutical companies, they won't, they're not giving free World Series tickets anymore, or whatever the case was, just for prescribing or meeting a certain quota on a drug. I'm so glad that the entities that are alive, I guess, got involved, because that's not right. Because then it becomes about drug being prescribed instead of patient care. And knowing you, William, I know you're a good clinician. You always talk about patient care. That's always something that you're always saying constantly, those two words, patient care. And that's something I admire you about that. And this is a perfect time to go to the next topic involving psychotherapy and medication, which is advertising, right? Advertisement. I'm no specialist in that, but every time I turn on, I'm not a big TV guy or whatnot, but I do watch a lot of YouTube, and I do read a lot of articles online. And when I go to my grandma's house and I see her have the TV on, I'm always seeing something about erectile dysfunction, heartburn, and so many other types of smaller diagnosis or with smaller symptoms. And they're saying, if you take this drug, it'll help. And sometimes it's over the counter, or sometimes it says, ask your doctor, or ask your doctor about this drug and whatnot. And it's almost as if the advertisements are put out there for the consumer to think, oh, if I take this drug, this is an easy way for my symptoms to be relieved. And there's a lot of misinformation in that, because from our previous podcast, we talked about how someone should take a look at their lifestyle, what they're eating, what they're drinking, what is their water intake, how are they sleeping, what are their relationships like, what is their job like. Instead of looking at those factors, it's almost like an easy way to just skip all that and just, I know about this medication now because it came out on the whatever platform it came out. I'm going to ask my doctor about it, or maybe not. I'm just going to take it. Do you find some sort of ethical issue in advertising these drugs? Because I had a conversation with my friend the other day. He says, not really, because people need to know what's out there. So I just want to see what's your take on that, because I find that to be a big, big hot topic.
Yeah. I think that, there's, you do see the side of the, whatever pharmaceutical company has, put out the resources to, get a drug to market, like we had talked about. So I do sympathize with the fact that, a lot of these medicines, and used in the right way, in the right patient population, can be life-saving in a lot of ways. There was a time when aspirin had to advertise as well, so and we know all of the many life-saving benefits of aspirin. So I think that there's, like everything, there's two sides to it. There's the side that says, we need to, educate the public about what their options are. But there's also the side to it where, if you're on an antidepressant, you see the commercial, you realize, well, I used to be feeling a lot better when I was first started on this antidepressant. I wonder if I need to switch to one of the newer agents. Then, the patient tears the advertisement out of the magazine, brings it to the office appointment and says, Dr. So-and-so, have you prescribed this at all? And that's kind of, where these conversations begin, from advertising to patient to then patient-doctor relationship. And then there's the outcome. So I think that, these agents would still get prescribed. The doctors could educate their clinic population with the newer options without those advertisements. But, I feel like, it's overdone. I feel like there's a place for it, but I feel like my opinion is that some of the advertising in the States, because it doesn't happen in every country. There's a lot of countries that don't have it all together in terms of the advertising pharmaceuticals. I feel like it's done to a point where, you start to question the motives there here in the States.
Yeah. And people start to question the motives. And despite people questioning the motives, people like myself and you'd be surprised how many kids do as well, because I work mostly with adolescents, and they did a research study here, and I'm looking at it at the National Institute of Mental Health, where here in the United States, out of every 4 people, 3 of them prefer medication over psychotherapy. Now, I'm not sure about the population and whatnot. I would have to really look at these details, but if 3 out of every 4 people prefer medication over psychotherapy, it's almost, I tell people all the time, that's the substance. It's almost like a cheat code, right, to what's already inside. And what I mean by that is, instead of addressing other variables in your life, you just want to take the substance just to relieve the symptoms. But that's the thing. The symptoms just get relieved. They don't get the real issues causing the symptoms doesn't get addressed. And
Right.
and I just want the public and the audience to understand that Dr. William and myself, we're not saying to do this or to do that. We're just having a dialect about medication use and psychotherapy and some of the statistics involved in this, and addressing some ethical issues involved as well, with the advertisement included. Now, William, with substance use, not substance use, excuse me, with medication, oftentimes, because I work at a residential facility, I work a lot with adolescents, and a lot of the adolescents, they every time they go to see the psychiatrist, because we have a psychiatrist come twice a week to see the patient, see how they're doing in the residential treatment setting, and seeing what's going on, what's their lifestyle like, how are they reacting to the drug that they were prescribed, the medication that were prescribed, depending on the diagnosis. And a lot of these adolescents, they don't want the medication. They hate it when the psychiatrist prescribes it. Some of them are more, they conform a little bit better than others. But some of them in the morning, when I was a BHT, I'm not a BHT anymore now, I'm a therapist, but in the morning when I was a BHT, some of them will be like, oh man, I don't want to take this, but I know I have to, because if not, they're going to kick me out of here. And honestly, it wasn't necessarily like that. But what they meant was, by those words, was, when I take this medication, I become like, if I don't have any energy, or they'll say, when I take this medication, all of a sudden I just become really focused and I don't get hungry. So there's a lot of side effects to these medications. But the reason I mention all this is because it's funny how the adolescents, they actually don't prefer not to be medicated. And I'm going to be honest with you, if they prefer not to be medicated, I always used to tell them that then they better reflect on their actions, stop and think before they do something. because
Yeah.
if not they're going to be almost, I don't want to say forced to take it, but they get a little bit pressured also by the judge as well. I've seen that before too, where the judge will say, are you taking your medication? And if the therapist in the courtroom says, Your Honor, he hasn't been taking his medication, or if the adolescent says no, then all of a sudden, this, I always have such a big issue with this. Then the judge feels the need to say, oh, you better take the medication. I'm going to be sure that you do. I
Yeah.
find that to be such a an ethical issue, and it's something that happens here in down south. So have you ever seen that? And according to that, out of every 4 people, 3 prefer medication. Do you think that that includes the whole population? Because I feel like that statistic may be a little screwed.
I think that the biggest thing that strikes me with a statistic like that is that the biggest difference in the time commitment to each treatment modality. So if you're talking about a medicine that you have to take once a day, let's say it takes you 3 seconds to swallow the pill, versus a consistent like psychotherapy regimen where let's say ideally it's once a week. You have to get in your car, get transportation, drive to the clinic, um, sit down with a therapist, 30 to 60 minutes, then kind of wrap up, drive on. I mean, you're talking about 100 times the time commitment of one versus the other. So I think that in a busy and stressed out world, that's going to be a major player. We want the easy fix, but I always challenge patients to think back to the first time they started having problems with anxiety or challenges with sleep. And usually it dates back years, right? So you've kind of been, spinning all these plates. Maybe one plate is depression, one is anxiety, one is problems with sleep, one is problem with focus, and you're trying to keep all these plates spinning on sticks. And you can keep it going for maybe 2, 3, 4 years. But then once these plates start falling is when you see the patient, right? Now they realize, okay, I need help with this. So you're talking 4 years back, this is when this happened. So it's not going to just get fixed by Tuesday. It's got to be an equal time commitment to undo it. Now, nobody wants to be told, I should have this sleep problem sorted out over the next 3 years, right? So, but one could make the argument from a psychotherapy side of things, peeling back, or why the sleep first got problematic. Was it a divorce at that time? Were you feeling pressure to perform at work or in your relationship? So getting down to that and to the point where you kind of start discovering where that pressure and problem came from, that's going to take months, right? And we've been talking about sleep, so Ambien will start working that night. You take it, it starts working in 60 minutes, and you can sleep through the night. But I think what we're both saying is that you need both. If you can not improve sleep with psychotherapy, then there's a place for on those nights where you really need to fall asleep and you got to perform a presentation at work in the morning. But this should be, as soon as I prescribe a medicine, depending on the presentation, I am telling them a date where I would like to have them off of it, especially these as needed medicines. So I don't prescribe medicines with a start time and no finish line. I'm already telling them and I'm documenting them. This is how we're going to work towards getting you off of it. So that my medicine initiation comes with a plan to discontinue it. And I'm always discussing about how we can reduce the dose, spread out the as needed doses, whatever we need to do. So that way it's not just a one-way street.
And I'm so glad you mentioned that, because in your treatment plan, I'm assuming you're including, okay, we're gonna start this now, but in the end, but this is the end date, and this is how we're gonna do it, and that's included in the treatment plan. I'm not sure, as a psychiatrist, as a psychotherapist, I do treatment plans and stuff like that. That's
Yeah,
why,
we
but
do as well.
and that's very interesting. And when you tell them that, though, you're obviously giving them the medication to suppress the symptoms, but what about the underlying issues, addressing the underlying issues? So when you're saying, okay, this is the end date, what in your treatment plan are you including to address these underlying issues, so the medication, they won't have to take it anymore, and the symptoms, they won't be as prevalent?
Yeah, so that's a really good question. So, let's take for the example, let's take somebody that has a panic disorder. We haven't talked too much about panic. So you take somebody that, comes to see me to establish care, and they come with one of their parents saying that they're having these panic episodes that are described as, kind of fear comes up to them without reason. They're short of breath. They can feel their heart racing. Maybe they're sweating a little bit lightheaded. And there is concern going on in the background that maybe they're not going to pass 2 out of their 5 classes in the semester. So these episodes now are happening 4 times a week, they tell me. So, I document this, and, we institute a plan to, see what the triggers are, kind of see how we can reduce these episodes. And they come back and see me in 4 weeks, and things aren't really better. So let's say I start a medicine like an SSRI to help with like the foundational level of the anxiety driving the panic. And the next time they come see me a month later, the symptoms are maybe down to 2, maybe 3 episodes of panic. But when they are having these episodes, they're really bad. So we start an as needed medicine. Okay. If you're having a panic attack, you take this. So if they get, 15, doses a month, say, of, something like an Ativan or benzodiazepine, I want, my whole goal of the medicine is that if after that first prescription, if they take that medicine 5 times in the first month, the next month I need to look at how we can get it so they only need it 3 times. So the more pills that are left over, that's kind of my pharmaceutical scorecard, so to speak. So I know that in implementing them in psychotherapy and them talking to a therapist or myself on a weekly to monthly basis, if they're not kind of keeping track of these episodes of panic and reducing their reliance on medicine, then we have to change. So it's kind of a dynamic treatment modality, but I'm always working to get the medicines off. And then, a long-term, antidepressant is one thing, but these benzodiazepines, they were really only prescribed to be available to a patient 2 to 4 weeks at a time. I see patients that have been on them for, 15, 20 years, which is, part of the challenge that we face as a specialty.
And that's what you were mentioning earlier, which is you never thought how hard it would be to get patients off the medication instead of trying to treat their symptoms. You're actually, now the symptom is the substance abuse that's happening. And
Right.
And we're gonna finish off with, if you don't mind, William, I know we're running short on time, but with one more topic, and that's that. I'm gonna read it here, okay? I wrote it in my notes. Obviously, before I even start, the Department of Veterans Affairs over the last 20 to 30 years, they've made post-traumatic stress disorder, their main topic, for obvious reasons. But so the evidence-based guidelines for PTSD treatment include cognitive processing therapy and prolonged exposure therapy. This is the Department of Veterans Affairs. This is the 2 type of treatment modalities they're using to treat PTSD. And then medications such as benzodiazepines are not recommended because there are demonstrated benefits of these medications in treating PTSD, but they also have harmful side effects, including risk for addiction, which is what you were talking about, overdose in combination with alcohol, and interference with some benefits of psychotherapies. Because if you're on the drug, then it's gonna affect your mood. It's gonna affect how you're going about just your overall way of being. But then this article goes on to say that despite all this information being presented to the patient, about only 30% of them, only 30% of the veterans prefer psychotherapy treatment. 70% prefer the drug, and that's such an interesting research and article that I was reading because, to be very honest with you, William, despite the person knowing, obviously the person is meets the criteria for post-traumatic stress disorder, so there's a lot going on there. But despite the person knowing that the medication can be harmful, there's a lot of risks involved, 70% still prefer the medication over psychotherapy. So a lot of people will look at this and say there's still stigma surrounding psychotherapy, especially amongst the soldiers. I guess you could imagine, more of a masculine type of group. But in my and from what I'm seeing, there may still be a stigma. But but there's also obviously not a lack of information because they're presenting it to them. I just think that sometimes the medication is almost a cheat code and it's an instant fix to the symptoms, but the real underlying issues are not getting addressed. So kind of this research sums up everything we were talking about and what you mentioned, which is both of them at the same time is probably the best, because you're on the medication, your symptoms are getting suppressed for the time being, but at the same time, you're also seeing a professional psychotherapist and your underlying issues are getting addressed. And that takes time for everybody listening, because if everybody thinks you go see a psychologist or a therapist and that's it. I mean, the relationship you form with the professional is important. And sometimes that relationship takes months. I mean, we would hope it doesn't, but sometimes it takes months, and it can be a tough cookie to handle. So I would like to close with that. Is there anything you want to say, William, to close the podcast? I really appreciate you having you on, man, as usual, bro. I mean, you give us such great insight into the world of psychiatry and to what happens in the hospital and a lot of your experience, man. And I really appreciate that, bro.
I appreciate that, man. And I'll just close by saying, you can, just for the touching on the point from the veteran population, we put PTSD under the umbrella of these anxiety disorders. So, I've heard anxiety described as in the past is, when you trip on a curb and you have that feeling where you're falling towards the ground, that 1 second feeling, and it's the most uncomfortable feeling in the world, and that there's going to be discomfort at the end of the fall. Anxiety is like that, only all day long, so that's something that really sat with me when I heard it. So I take the veteran population. You realize that there's a desperate need for something that reduces the anxiety, and you take something like a benzodiazepine, and it has no side effects, really, maybe some sedation, but it works right away within 15 minutes of the dose. So it's the providers, yours and mine both, responsibility to say that this is only one section of the treatment. This is not the main deal, and everything else supports that. It's got to be a multiple equal prong approach to the treatment. So I appreciate you having me on, and we'll continue to talk about these topics for sure.
Absolutely, William. I look forward to next week, okay? Or the week after, whenever you have a chance. But I appreciate you, man. And we'll be in touch, okay? And thank you, audience, as well. I appreciate all of you. I'm sure Dr. William Bridge does as well. And take care and be safe, okay? See you, William.
Thanks, man.